Thank you. Thank you. Well, I am excited both to introduce and to showcase the Connected Health Innovation Challenge. This challenge actually has been over a year in the making. It's a part of a much larger group effort. And based on what you're going to see today, I can tell you I'm very excited both about the ideas and the presentations they've put together, but also about the future of the challenge itself. When we first started thinking about doing this innovation challenge, we basically knew two things. One, we wanted to provide a platform for early stage concept development. So this is not where people are necessarily at the demo, which is other innovation challenge that you see, but this is really early stage concept development for anyone who worked within partners so they could showcase their ideas. After all, these are people that are on the front lines day in, day out, providing high quality care, which gives them a front row seat to saying what's working well, as well as what places might be ripe for improvement or for some novel ideas. Second, we knew that we wanted to provide not a cash prize, but service. That instead of handing people money, we thought we would hand them a team. We would give each team some of our own staff and encourage them to develop the idea, give it the time and attention that it deserved. And for us, we thought there were benefits across the board that it made sense to do it this way. For the applicants, it gave them an instant staff to give an idea that maybe just hadn't seen the light of day, hadn't had the attention it deserved, and help it go from just a vision to an actual working concept. For us at Connected Health, for our staff, it made sense because it allowed us to work with new colleagues on ideas that were fueled by evidence and passion and put our user-centered design process to a new test. And for partners in general, we thought it made sense because it fit really nicely into the overall mission of focusing on patient-centered care, being a leader in integrated healthcare systems, and being a part of the community. So this still was our first time out. So if I'm being totally honest, I will tell you there are pieces of this that were done by the seat of our pants. But just like innovation itself, the path isn't always clear, the timing isn't always perfect, and sometimes you really need to understand that adaptation is not just a necessity, but a normative part of the process. And just like innovation, sometimes the best ideas actually come in the most unexpected ways, and if you don't allow for that adaptation along the way, then you're really robbing yourself of the possibility for serendipity and some of the best things that might come. So, even though we thought that we had considered all the avenues and mitigated all the risks, there certainly was elements of this that we adapted along the way. But we believe so strongly in the concept itself and the spirit of innovation of partners, and quite frankly, the capabilities of our staff to provide the service, that we figured if we built it, they would come. And come they did. Over 200 people with over 50 teams came together to apply. Some of these teams were comprised of staff that had worked together for quite some time, while others came together explicitly for the purposes of this challenge. In addition, people brought with them external people, so people that didn't work within partners, but they were associated with them, which really made for this mix, this rich mix of ideas and experience and expertise, all of which went into the applications. As you can imagine, for the review teams, this made the decision-making very hard. It was an incredibly high-quality pool of applicants, and it once again reminded me how grateful I am to be a part of this digital health world. So the review committee, which consisted of many Connected Health staff members, we had a senior committee of Greg Meyer, Zhang DO, Srikanth Shagaturu. We had our work cut out for us. We whittled the applications down to the top 20, then to the top 8, and finally the top 2. And those 2 are the ones that you're going to see today. Each of those ideas, those applications, were assigned a team, and off they went. 6 weeks later, they came back together and in a live pitch-off event that was open to the public, so anyone could come, and we encourage anyone to come outside of partners as well. They presented their ideas, and it was exciting to see how far they had come. I mean, really, when you're going from just words on a page to actually seeing something, it really is stunning to see how it comes to life. It was also exciting to have the public participate in the vote itself, to see who the grand prize winner would be in this inaugural challenge. And this is actually one of those areas where openness to serendipity comes into play, because on the day of the live pitch-off event, Shree's wife actually went into labor, and so he couldn't attend, as you can imagine, the live pitch-off. So we weren't expecting to have the public be a part of the vote in the way, but it turned out so well and was so exciting that it actually is something we're going to build into the challenge going forward from here in an even bigger way. So that was one of those examples of just allowing serendipity to take hold and actually having a huge benefit. So a grand prize winner was selected. You'll see them today as well. And they had another 2 months to work with their team to take it even further. So they took it to interactive prototype. And from there, you'll see it from there on. And I'm actually going to turn it over to them. So the first team you'll see is the runner-up. That is Dr. Rebecca Scully. She's a physician in the Department of Surgery at Brigham and Women's Hospital. And Gabriel Martinez Santabanez. He's a user-centered design strategist at Connected Health. And they're going to present to you about their concept for a fast, mobile, low-cost screening tool to diagnose peripheral arterial disease. So please welcome Rebecca and Gabriel.
Hi, my name is Rebecca Scully. I'm a general surgery resident at Brigham and Women's Hospital here in Boston. I'm going to tell you today about the project that we work on. It's the Vision app. It's a mobile screening tool for peripheral vascular disease. So let's start with a patient. It's always a good place to start. So imagine yourself as a PCP. You're in a busy clinic. Your schedule is stacked. You walk into a room, and there's a 65-year-old guy, and he tells you, "My legs hurt." It's one of those chief complaints that can be almost anything. You know, is this osteoarthritis? You do an exam, it's not quite right. Is this sciatica or a neurogenic problem? Still, you're not quite sure. He's on a statin. Could this be a medication complication? He's also a smoker. He's a little bit older. Could this be a thing called peripheral arterial disease or PAD? You're not really sure. You know, what do you do next? Do you send them to an orthopedic surgeon? Do you send them to, a neurosurgeon? Do you send them for more testing? If so, what testing? You know, is this something that's an emergency? Do they need to go to the emergency department? Or can you send them home with some pain meds? It's pretty tough. You're trying to make a quick decision on something that's pretty important, and you're doing it on imperfect information. So what is PAD? Younger people, a lot of people haven't actually heard of it. It's sort of similar to the hardening of your arteries in your heart that can lead to an MI or a heart attack, or the hardening in the arteries in your neck, which can lead to a stroke. It's a similar process. It's the buildup of plaque in your legs and the arteries that bring blood flow to your legs. So when you walk, the muscles in your legs don't get enough oxygen, and your body reads that as pain. At its sort of less severe form is called claudication. Basically, you walk a couple blocks, your legs begin to hurt, you stop, it gets better. It's not life-threatening, but it's debilitating. People aren't able to get around, they're not able to do the things they want to do, they can't do their activities of daily living. At its more severe form, called critical limb ischemia, the pain is constant. It never goes away. It can lead to tissue loss, it can lead to gangrene, it can lead to amputation, and it's an independent predictor of all-cause mortality. For people over the age of 65, 12% of the population has this disease. People over the age of 85, 30% of the population has it. In the US, there are 8 million people dealing with this every day, and worldwide, there are an additional 44 million people. So how do you screen for it? How do you pick it up? Well, the PCP can actually screen for this in the office. You can do something called an ankle brachial index, or an ABI. What you need is a Doppler, and you need blood pressure cuffs, and you need time. And that's something that no PCP has today. To that point, 70% of PCPs have said that they've never actually done this. Further complicating it is that recommendations for screening are a little bit unclear. It's something that you don't want to miss, but it's not always right at the front of people's minds. Your other alternative is to send people to the hospital to get formal vascular testing. When you get the ABI number, but you also get these pulse volume recordings, the PVR waveforms that you see. It's a lot of information. It's the information that a vascular surgeon needs, but not the information that a PCP needs. If anything, the test doesn't make it easier for you, it makes it a little bit harder. So because of this, because of the time, you're asking a patient who can't walk to go to the hospital to get another test. Often in vascular clinic, we see these people 6 months, 8 months down the road. They've seen they've seen orthopedic surgeons, they've seen neurologists, they've been on pain meds, and it's only getting worse. And it took a long time to finally get around to the diagnosis of PAD. So in this, we saw huge unmet needs. not only is there burdens and barriers to actually screening for it, once providers have this information, they don't really know what they're supposed to do. If it's critical limb ischemia, CLI, that's an emergency. If it's just claudication, then it can kind of wait. There are a lot of things that you need to know to how to manage this, and it's something that PCPs deal with all the time. Like, how do they appropriately triage patients? So what we thought, at around this time, it was becoming a kind of a popular idea that you could be able to monitor somebody's heart rate using video, sort of a no-touch vital sign sensor. Like, oh, if you can pick up someone's heart rate, you could probably pick up blood flow to a specific part of their body. Basically, all PAD is low blood flow to your foot. So what we did is we gathered a cohort of patients at the Brigham that we knew had PAD, and we took videos of their feet. We took 30-second videos of each side of each foot, and then we met with a guy named Dan McDuff from the MIT Media Lab, and we're like, we have all this video, what can we do with it? So he said, what we could do is use independent component analysis, and we can split that video into a waveform. So you can see in the right leg, there's a nice waveform during diastole, there's a low flow, during systole, there's high flow, sort of the lub and the dub of your heart. And you can see there's a nice peak, and that the blood is getting down to that foot is okay. On the left leg, you can see that the waveform is heterogeneous. It's choppy, there doesn't really ever have that nice peak. Not enough blood flow is getting down to that patient's foot. What we can do is use components of these waveforms and then correlate them to the ABI that's measured in the vascular lab. So we did that. We took 30 patients and 60 limbs, and we tried to put it all together, and lo and behold, it worked, which was great. So then what we did is we got Gabriel and his team involved.
So Rebecca's team came to us with a really interesting challenge. How do we turn this really interesting technology into a product that people actually want? So part of the value we provide at Partners Connected Health is our user-centered design consulting services. So what is user-centered design? At the core of it is the user. It's a deep understanding of user needs, their wants, their limitations for completing goals or their tasks within their environment, and that's what we investigated. So why is user-centered design valuable? It brings products, it helps us build products people want that actually are useful, valuable, and it makes them fun to use. It also helps avoid common mistakes and wastes of resources, like solving for the wrong problem, designing for the wrong person, or possibly misaligned incentives. So why are we different? What special design thinking strategy are we using? The truth is that all of the design strategies work. What we're different is because we are genuinely curious. We have designers, we have scientists, and we attack the problem from a diverse perspective. So during our ethnography piece, we asked questions about how the screening's made, what information is necessary, when is information necessary, what is the difference between the needs to have versus the nice to haves, and also why, lots and lots of whys. And my favorite question here was, why are people not doing the screenings? So we sat down with PCPs, with MAs, with PAs, and vascular surgeons. And some of the things that came through the interviews were, I've never done the screening before. I don't have the tools. It takes too long to get the results to come back from the labs, or flat out, I don't want to do it. I want someone else to do it. So we took what we learned from these interviews and we created a short list of product requirements. So we learned that the screening could take 20 minutes and the actual PCP visit's about 20 minutes. So obviously that's not going to work. So our goal was to shrink that down into the sliver of time we have during the vitals collection. So we wanted to shrink that down from about 20 minutes to 2 minutes. It was also important to communicate pad severity. So that being, some clinicians did not necessarily know how the scale worked when it comes to risk. It also needed to be simple because many people would be using this and it needed to be connected to the cloud. So all this together was important for making a minimal viable product. So who is our user? So take a step back. Who's already with the patients? Who's already doing screenings? The nurses are. The nurses, the MAs, the technicians. So let's pretend that we have a nurse. Let's call her Martha. And maybe Martha is set in her ways and maybe doesn't necessarily know how to use technology. Maybe she's not tech savvy. That's totally okay because for the app that we've prototyped, there's only one button. All she has to do is press the start recording button and it takes her through a guide. So here you'll see Martha will only see a video of the patient's arm or the leg. However, to our friends at MIT, they'll be able to see color waveforms which are able to predict the ABI. So in this case, this patient's ABI is 0.68. and their risk is mild to moderate. So at this point, the nurse can either type this into the medical record, or she can export a PDF here with a little bit more detail in this report. So what we've done here is condense a really complicated process of scheduling appointments, coordination, 2 weeks of waiting for lab results, and squeeze that down into a sliver of time, 2 minutes. That can happen during the visit. It saves everybody time and money. It's a tool that fits in your pocket and also fits into your clinical workflow.
So our hope is by lowering the barriers to screening that all of these patients will be able to get the screening that they need earlier, that patients will get to the place that they need, they'll get to the provider that they need to help them start to feel better. Once we diagnose you with PAD, we can start behavioral modification, we can get exercise, you can start exercise programs, you can stop smoking, you can start a statin, you can start aspirin, you can start Plavix, you can get a surgery if you need it, a stent if you need it. We can help avoid the pain, the loss of ability, and the disability, and the need for amputation for these patients only if we know and only if they get to the people that can take care of them. So where are we now? I told you that we did a 30-patient pilot, and that's done. We also completed our design and feasibility stage. We're now in the process of building MVP1 with the hope of getting a research-ready app. So we'll be able to do a multi-center trial, both to refine the user experience and then also to be able to continue to refine our algorithm. Looking forward, we sort of focused on primary care providers and vascular surgeons initially, but this is something for a patient that knows they have PAD. If they're doing an exercise intervention, they can monitor themselves to see, if they're getting better, if they're getting worse, if they need to come to the hospital. For someone who's had a surgery, they're going to be able to check to see if their stent goes down. They'll come in to be seen much sooner. For vascular surgeons, this could be real-time feedback in the operating room. Is your bypass good enough? Did you do a good surgery before you close and leave? Also, there are not enough vascular surgeons in the United States, and the problem is only getting bigger as the population ages. PAD also tracks really strongly with diabetes, so the number of people with this disease will only continue to increase. So for telemedicine to become a bigger part of care, it's really hard to diagnose PAD just on history alone. So with this information, people could be triaged and screened who otherwise would not have access to a vascular surgeon. And then in sort of the bigger sense, in trauma and mass casualty events, if you're trying to triage patients and you're not sure, you're worried someone's going to lose their leg, this would give you, instant feedback on, if you need to get that patient to the hospital right now or if, someone else can go first. This has been a huge labor of love. There's been a lot of people involved, a lot of clinicians, people from MIT, the User-Centered Design Group. It's been a really great experience for us in the Connected Health challenge, and Gabriel and his team really got us to where we are now. So it's been a huge learning experience, but it's very exciting for us. So thank you all for your attention. And then I think we're doing questions over Twitter, so feel free to tweet at me, Becca_Scully. It's in the program. And then I think we're going to hand it over to the next group who will tell you all about what they did.
Thank you, Rebecca. So I heard her mention Twitter, and I do want to make a plug for Twitter in that this doesn't really afford us an opportunity for Q&A, but as popular culture parlance, operators are standing by. We really invite you to take to Twitter. You can use the CHealth16 hashtag to ask questions that you might have, either of the presenters or of the challenge in general, to make comments to keep this conversation going. One of the things we've heard at this conference as well, the beauty of social media is that these conversations can continue today, tomorrow, next week, for weeks to come. And we're excited about this challenge. And again, these are novel ideas, and so as you have questions, please do ask away. People are waiting and ready to respond in live time. So that's my Twitter plug. Next, really, I just want to introduce the grand prize winner. As I said, this team was able to go a little bit further in their development, and being one of the people that received the initial applications and just seeing it as black and white on a page, and how far they have come to what you're going to see today really is transformational. And so I'm excited to bring them up on stage. This application was also interesting in that it was a family affair led by Dr. Alden Doerner Rinaldi, who's formerly a palliative care fellow at MGH, now at Mount Auburn, his wife Dalia, their brother Jack. So that made it a unique flavor as well. They partnered, and you'll see today, Scott Newland, who's one of our senior user experienced designers at Connected Health, to bring Embodie, which is, it's a way to increase the care team's ability to provide high-touch, high-value care for individuals living with serious illness. So first, I believe I'm going to bring Scott up onto the stage. Please help me welcome Scott Newland.
Hi, everybody. Thanks for having me. As Jody mentioned, my name is Scott Newland. I am a user experience designer with Partners Connected Health Innovation. And I'm here to speak with you all today about the Embodie project, specifically about the creative process involved. Now, Alden's going to get up on stage here in a moment. He's going to speak to you more about the necessity of this project and how we hope it can really influence care going forward. But for me right now, I'd like to take this time to speak to you about the design thinking that went into it. So to begin with, what is Embodie? To put it simply, Embodie is a tool designed to help a patient and a doctor communicate about a patient's chronic pain. And we're specifically focusing on oncology and palliative care fields of medicine because these are fields of medicine that deal with serious illness, which chronic pain is no stranger to, right? So what is the issue that we're trying to solve within that relationship? When we deal with pain, as I think everyone in this room can relate to, that is a very visceral experience, right? And so when we get into the exam room and we're asked to unfold all that, and the doctor says, how are you feeling? That tends to come with a lot of emotional baggage that we feel we need to unpack. But from a doctor's perspective, they tend to have a finite amount of time in that exam room, which means that they're trying to get to the facts in order to inform a diagnosis. And they don't have all that time to develop to that empathetic ear that we're trying to get at. But that's important for you to feel heard as a patient in terms of remedying your pain, right? So we were working with Embodie trying to figure out, is there a way that we can begin to leverage the tools that we all have access to today and just use them in a smart fashion that can help fill that divide? And we think that there is. But that still implies some degree of change take place in that experience. And change is not always the easiest thing to do, right? It can be difficult because it relies on a number of things. Change relies on an open mind, a willingness to be persuaded to think differently, and a sustainable relationship, which is to say that change basically relies on trust. Now, I'm not speaking about trust in the user experience sense of the word trust, where I expect that this app or this product will open up and respond as it typically does. There is still design cohesion in this product. Yes, all those things are important, and we have taken considerable efforts to make sure that is baked into this product. But when I speak about trust, I'm speaking about the relationship kind of trust. The trust that is established through repeated, consistent use and is earned. And that is not something that is immediately apparent in a product. It has to be developed through something like engagement, right? But in this media, engagement is one of the strongest hurdles that we have to overcome, which I think all of you guys will recognize. Take, for instance, this graph done by Quetra. This was done last year, where they studied the typical Android app over a 3-month period of time from the date of install, and they measured the average user retention rate over that period. We noticed that within the first 48 hours, we lose something like 75% of our users. That is remarkable. Consider the fact that this year alone, 1 out of every 4 apps that we download will be discarded after the first time that we open them up. That is an incredibly short window of time for us to build just a trusting rapport with our users, right? So what does that mean for us? Well, for us designers, it means that the vast majority of the time, we are just elated that you opened up the app. And when you finally do open up the app, we're actually sitting there telling you, here are all the ways that you can change in order to live a more fulfilled life. But we're still reaching you with change. So that is a tough sell to make, right? So we need to build in things to this product that actually make it more incentivizing or appealing to our users. And at Partners, we do things like this: baking in understanding, empathy, motivation, and shared purpose. We will go out and spend a considerable amount of time in the field to understand where the friction points are for our users, where their needs are, and where they're not being met. And then it's important for us to go back to those users and say that we understand where you're coming from. We're empathizing with you. This is important to you, so it's important to us as well. And beyond that, we need to find ways to incentivize them to reach their goals to change. That's dealing with motivation. And with shared purpose, everything about our product needs to reflect intention and purpose. And not just that, but it needs to be a purpose that really resonates with our users. So in the instance with Embodie, when we're talking about understanding, how do we understand where this is friction now? One of the first things that we can do is actually study how we're measuring pain today. And that brings us to this. We have the 0 to 10 pain scale, which I think everybody can relate to in the audience. We've all done this before. And we have the McGill Pain Questionnaire, which I wouldn't be surprised if nobody in the audience recognizes, but clinicians love this. To begin with, on the 0 to 10 pain scale, we love this one because as patients, because it is super convenient, right? We can communicate to our doctors in one breath how we are feeling. But when we are in the exam room with our doctors, that is not the only piece of information that they are weighing in their assessment, right? They're also considering their observation of us. For instance, is our voice breaking? Is our body trembling? Are we sweating? That is contextual information that is very important in terms of making an assessment of pain. But when we translate this experience into a digital experience, we tend to do so at the sacrifice of all that contextual information. Which means that yes, this is very convenient for us, but is not nearly as informative as we would like it to be. On the other hand, we have the McGill Pain Questionnaire. Now, this is a form that was developed in 1973. And anybody that's ever had to fill it out can actually feel that date. It takes about 5 minutes to complete, or somewhere in there. And if you're in pain, that is an incredibly long period of time to fill out a form. Beyond that, it uses language like this. Smarting. When was the last time any of us ever used smarting to describe anything, let alone pain? The Simpsons can get away with it in their caricatures, but that's not necessarily the typical norm, right? So in 1973, this form might have been appropriate. In fact, it was. But fast forward to today, and we find ourselves living in an experience economy, where something like this no longer meets us where our needs are. That said, efforts have been made to make this into a digital experience, but those efforts tend to be more akin to something like this, as if putting a touchscreen on it is going to solve all its experiential issues. We look at this and we think that we can do better. For instance, the body map alone, that's like a territory now that we know that we can customize this. We can actually make that an engaging experience just in that element by itself, right? It no longer just has to be a map where we can plot pain points onto. We can actually turn this into some degree a canvas for some amount of self-expression. And maybe it can actually respond to a user's input to actually communicate in a visual way how a patient is feeling. But to be fair, even that is only going to get you so far. That only goes so deep. When we look at this form, we're actually trying to tap into empathy. So how can we communicate that into our experience that we're creating now? When we look back at this questionnaire and the forums and the research that we've done, and we said, are we even asking the right questions? And we thought there was one question that we weren't being asked. And that is, has this pain prevented you from achieving your goals? Now, this is really important for us to ask, because as a user, this is what pain does to us. It stops us from doing the engagement that we want to do, like take your dog for a walk, cook for your wife, or play with your grandkids. That's what pain does. And so as a user, this means something to me when I read this. It says that the person who's asking this question is actually wanting to get at this because they understand that this is important to me. And not only that, they're also telling me that this is important to them. And that's what we're trying to do with Embodie. That's empathy. That's understanding. And that's shared purpose, right? But when we talk about our users, it's important for us to keep in mind that we're not just designing with one user in mind. In this instance, we're designing for two. We're designing for somebody like Alice, a patient who has breast cancer, and her doctor, Dr. Lee, her oncologist. We need to find a way to incentivize both of them to come to the table and engage in this product equally in order for it to be successful. So how do we engage Alice? Well, in Alice's instance, she wants to provide her doctor with more qualitative information, right? Well, that's great because that's what Embodie does. Embodie can reach out to Alice periodically throughout the week and just check in and say, hey, how are you feeling today? Has that pain that you reported last week, has that changed at all? That way we're able to collect a collection of data points that we can share with Dr. Lee in a digestive way that she can make sense of this. And we actually have a holistic picture for her. That's something that helps Dr. Lee out, and it also allows Alice to play a more participatory role in her care, which is something that Alice wants as well. She doesn't want to just be a spectator. But somebody like Dr. Lee, on the other hand, she still has a time crunch that she has to get beyond. So is there a role that Embodie can play there? And we think that there is. Consider the fact that if Embodie were to reach out to Alice a week before their appointment and say, in order for us to be able to optimize the amount of time that you have in the exam room with Dr. Lee, would you consider answering A, B, and C questions to help her with her clinical notes or to help inform her discussion so that she does not have to ask those questions when she's in the room with you? She can come prepared to already have that conversation. Right now, we're hoping that in this current process, we have a doctor and a patient and a gap that needs to be filled in terms of the way that we communicate. And by leveraging the technology that we have today, we would like to enrich that conversation, to fill that divide, to make sure that that conversation that's taking place is more substantive, is more informative, is more caring. And that's what we're trying to get at with Embodie. Because in that moment, when they're in the exam room, can we expect that as they're both using the information that we've collected with Embodie, that a degree of trust might be able to be established between both of them? This was a little bit about the process that was involved in us to get here. Aldo's going to get on stage and he's going to tell you more about how it actually goes beyond this from a macro scale. But to say that this was a multidisciplinary process would be entirely accurate. We worked with doctors, patients, clinicians, designers, all bringing them to a table to establish that multidisciplinary creative thinking. And that's typically how we designers approach projects. That's kind of like our secret sauce. We actually have to have input from everybody at the table. But in this instance, it was a little bit different from me. And I say that because I always approach my problem solving from that kind of mentality of how can I put myself in another person's shoes, understanding that the solution is not always going to be A plus B equals C. It's not always that linear. Human behavior tends to be a little bit sometimes nonsensical. And what resonated with me the most is that when a doctor, after a design meeting, pulled us aside and said, I want you guys to know that this experience has really resonated with me. That I find myself bringing this design thinking approach to my clinical practice, to the problem solvings that I deal with when I'm dealing with staff and I'm dealing with patients. And that was a reminder for me because as a designer, I tend to get tunnel vision sometimes and think that the design outcome is always the benefit of a product. As long as the product reflects that design, then it's design, 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 empathy, empathy, empathy into a product. And I don't actually realize sometimes that the design process in and of itself can be a product and can have potentially just as much influence as the end result does. And Embodie reminded me of that. So with that said, I'd like to invite Alden on stage now so that he can tell you a little bit more about this product and how we hope it can influence care going forward. Thank you.
Thanks, Scott. Hello, everyone. My name is Aldo. I'm a neurologist and a palliative care doctor. I really love medicine, both the art and the science of it. My colleagues do too. That special trust with which patients and families bring you into their lives, it's an amazing thing. That's what gets us through the long calls and the years of training. Beneath all of the wizardry of modern medicine, it's actually pretty simple. It's always all about people. Though sometimes we can lose sight of that. But once upon a time, medicine was really personal. Our family doctor lived down the street, knew us from birth, has taken care of us our entire lives. Today, it's a little more complicated. We have a torrent of individualized data, from our wearables to our genomes. It's individualized, but it doesn't always feel personal. In person-centered care, it's not just data-driven, it's relationship-driven. And the sicker you are, the more you need that relationship-centered care. So we created a digital health tool for patients and doctors to help them communicate and connect. But first, I want to talk a little bit about cancer. Look around the room. 1 in 3 Americans will get cancer at some point in their lives. That little wave of dread that you may have just felt, imagine what an actual cancer diagnosis must feel like. We're getting better at treating cancer, and we're pretty good at treating cancer symptoms as well. But that feeling of being turned upside down, only relationships can relieve that, like the ones that you have with your doctor. So it turns out that human connection, it's the secret sauce of medicine. And empathy itself, it can heal. It's not just placebo. Good communication with your doctor, it can alter your physiology on a molecular level, standing down your sympathetic immune nervous system, and even reducing inflammatory markers in your blood. So we know from the research that relationship-centered care, when focused on quality life and delivered early, it doesn't just help cancer patients live better, it can even help cancer patients live longer. That's that human connection again. Calming that whole person distress. But this approach, it's not just feel good. It's that kind of alchemy that we're all looking for in medicine today. It can improve outcomes while also reducing costs. Our society needs us to deliver more of this. But it's going to require many more hands on deck. The problem is the number of Americans living with cancer, it's growing fast. Way faster than our profession is. We simply cannot train our way out of this problem. That gap, it's not just a public health issue, it's an existential threat to the person-centered values that are at the core of the medical profession. And asking our doctors just to do more, it's not going to work because there are actual human limits to the human capacity for relationship making. Social neuroscience tells us, from Facebook networks to Amazonian tribes, that the human brain, it can manage about 150 relationships. Meanwhile, we have roughly one oncologist for every 1,400 Americans living with cancer. We also know that the brain has two cognitive channels for problem solving. One is social, and it thinks in parts, and the other, it's mechanistic, and it thinks in parts. The catch is that you can only use one at a time. And our outpatient specialists, they're making about 150 discrete technical decisions every day. So while chronic disease requires continuous whole person care, an explosion of data complexity from the clinic to the lab, it's keeping patients and doctors focused on the cancer rather than the person living with it. As a patient, what does that mean? Let's ask Alice. Remember her? Alice has breast cancer. She's experiencing pain. Her children, her grandchildren, spending time with them, that's the most important thing to her. But it's getting harder for her to keep up. She loses sleep at night, worrying that she's just not going to be able to stay active for much longer. When she comes to the clinic, she wants to unpack all of this. But she starts with her grandchildren, and it stops there. Dr. Lee, she redirects the conversation almost immediately. This is actually pretty normal. Observational studies have shown that doctors, on average, will interrupt their patients 18 seconds after they start speaking. Why? Dr. Lee, she loves her patients. The problem is she doesn't have the bandwidth and time to really deliver the kind of care that she expects and deserves. The time is short. She has 2 patients in the waiting room, both of whom are expecting and waiting for her attention. She has tough decisions to make and even tougher things to share with Alice. Meanwhile, in the back of her mind, she has all the unread emails, the unwritten clinic notes, the calls to return, all of the pile of things that it takes to make a clinic work. It's no surprise that 45% of Dr. Lee's colleagues say they feel burnt out. So we want to empower Alice, but we also need to recruit her, engaging her to put her patient-generated data to work so that Dr. Lee can best advance her care her way. That's why we created Embodie. It's a radically patient-centered app to track and better care for cancer symptoms. It's both scientifically rigorous and empathetically designed to present actionable clinical data and foster connectivity where it counts. Alice uses Embodie almost every day. Even when she's not feeling well, when she opens the app, her mood brightens. Embodie's relatable avatar, it's unique, just like her. A check-in, it's usually pretty fast. She uses it to track the severity of her pain, but more importantly, how it's interfering with her day. Embodie can go deeper when it's needed. It can follow up other symptoms like fatigue, anxiety, nausea, while also helping her set goals and monitor progress. Alice gets assurance knowing that Dr. Lee is listening all the time on the other side. And Dr. Lee, she can set alerts and she can check in with her own clinician dashboard to get a sense of how her whole patient panel is doing in one place. A quick tap, and she can get closer to Alice. Another quick tap, she can message or call her, either to change a medication maybe, or set up an earlier appointment. Dr. Lee, she gets an email before all of her appointments. It's digested and synthesized for her ease. Alice's questions, her agenda, and all of the things that Alice wants to share with Dr. Lee, they're right there. They're headlined. Embodie's algorithms have already analyzed the information from Alice's symptom log and present the clinical data in image and text in a way that Dr. Lee can grasp and document in seconds. The key for Dr. Lee is that she can easily identify and effectively respond to the needs of every patient she cares for. So when Alice and Dr. Lee meet again in clinic, Dr. Lee comes to the exam room already knowing how Alice's symptoms have been, but also knowing better who Alice is, how she's managing her disease, and how she's making sense of everything. Dr. Lee, thanks to Embodie, can now start the clinic visit asking, Alice, how are the grandkids? Alice doesn't just feel heard, she feels understood. Empathy, it can be primed, and we can help doctors manage more relationships with more authenticity. That's how Embodie creates value for patients, doctors, and healthcare systems. First, Embodie makes self-management easier for patients with an open channel of communication that they trust and even can enjoy using. Second, Embodie can make patient-centered care easier for physicians with automated clinical algorithms. And third, Embodie leverages the patient-generated data of 1,000 Alices to extend digitally our physician workforce and save time and stress for doctors. So there's an urgent need for this product. So we want Embodie to spread horizontally with the lowest possible barrier for all users. Because the value of Embodie will grow as it does. We're starting with cancer, but we're thinking bigger about this. With big data of human experience, of patient experience, We can iterate a tool, much like the way that I was trained as a physician, to become more diagnostic, more predictive, more supportive. So imagine an intelligent digital physician extender, or even an empathetic virtual cancer care concierge. The needs are enormous, and the solutions, they already exist. We just need to bring them together. We can harmonize technology and the art of medicine by design and make cancer care genuinely more personal once again. Thank you, Connected Health. Thank you, everyone.
Thank you, Aldo. And if they would indulge me, if I could get everyone who was the two teams to come on the stage just for one final acknowledgement, to Scott and Rebecca. And could we give them just one more round of applause for the work they've done? It's taken hours and hours and hours. And also, this challenge would not have been possible if it wasn't also for the incredible help that we got from almost every single person at Connected Health, whether it was the hours they spent reviewing all the applications thoroughly or all the tasks that go into carrying off something like this. So thank you to the Connected Health staff as well for the support to help this actually launch into a real project. So actually the response that we've gotten both internally and externally from this has convinced us that not only should this become a part of the Connected Health fabric of what we do, but really over time, we're going to help to grow this even further. I mean, we know that healthcare is everywhere, and healthcare happens every day. And the point of this Connected Health Innovation Challenge is to really encourage these early stage ideas, help develop them, make them meaningful for their intended users, to help both within and beyond the healthcare setting improve the patient experience. So thank you again for your time and attention, and enjoy the rest of the conference.